You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 4th, 2020. This week, COVID, trust in the FDA, and part 1 of an ESC recap including SGLT2 inhibitors and studies on atrial fibrillation. The COVID update, again, is simple. It's still bad. Cases are down here in the U.S., but deaths continue to be way too high. The big news is how the FDA will handle the coming vaccines. The worry is that a vaccine will be released without proper trial data. Politics is in the mix. And speaking of FDA, everyone has probably heard how our FDA Commissioner, Stephen Hahn, misrepresented the results of the observational trial on convalescent plasma use. Now, he explained that a 35% relative risk reduction was equivalent to saving 35 lives out of 100 patients treated. That is an absolute risk reduction. Now, that's a big error for a medical student, never mind the head of the FDA. Obviously, people suggested that this error may have been politically motivated. Hahn apologized publicly the next day, but Medscape editor-in-chief, Dr. Eric Topol, was not impressed. Topol penned a very, very remarkable letter to Dr. Hahn entitled, "Dear Commissioner Hahn, tell the truth or resign." Now, I call the letter remarkable because in an era when tone is heavily policed, Topol's plain speak and candor is truly stunning. Now, he lays out in this letter Hahn's mistakes, relative risk versus absolute risk, the fact that the convalescent study was a preprint, not peer-reviewed, it was an observational study, and he was presenting a subgroup of an observational study to boot. But that's not all. Topol gives 5 reasons why Hahn's apology was insufficient. I would highly recommend reading this letter. Now, I lead the podcast with this because the main thrust of TWIC is the evaluation of clinical science. And now, as we get ready to adjudicate the COVID vaccines, the matter of trust in scientists and regulators could not be more vital. Let's move to ESC. Now, my colleagues at theheart.org and Medscape Cardiology have done a great job with coverage. I would go and read their coverage. In 20 minutes, I can only hit some of the highlights. And this is part 1. Next week, I will review more studies from ESC, maybe even a part 3. 2 studies presented as hotline trials at ESC strengthened the evidence for the sodium glucose cotransporter 2 inhibitors, SGLT2 inhibitors. This week, I will review the EMPEROR reduced, which is EMPA versus placebo in heart failure, and the DAPA-CKD, which is dapagliflozin versus placebo in CKD. Now, recall briefly that SGLT2 inhibitors reduced renal tubular glucose reabsorption. That produces a reduction in blood glucose without stimulating insulin release. Now, other benefits include reducing blood pressure and weight. EMPEROR Reduce, which was also published in the New England Journal of Medicine, was presented as the first hotline trial. 3,700 patients with heart failure with reduced ejection fraction, about half with diabetes. It was empagliflozin 10 daily versus placebo. The primary endpoint was CV death plus heart failure hospitalizations. 19.4% in the EMPA arm versus 24.7% in the placebo arm. The hazard ratio 0.75 with a highly significant p-value. That's a 25% relative risk reduction and a 5.3% absolute risk reduction. The components of the endpoint differed. You had a 31% reduction in heart failure hospitalizations and an 8% reduction in CV death. Empagliflozin had statistically significant effects on renal outcomes. This was not seen in the DAPA heart failure trial. EMPA also had beneficial effects on the primary endpoint in all subgroups, including the group taking sacubitril/valsartan. Now, the big discussion point is that the primary endpoint in EMPEROR was driven by the non-fatal outcome of heart failure hospitalization. The confidence interval for CV death included 1, so you might say that the results were non-significant. And this contrasts with DAPA-HF, where CV death was 18% lower, and the confidence intervals did not include 1. By email, the PI of the EMPEROR trial, Dr. Milton Packer, reiterated what was outlined in their paper. He said, first, CV death in DAPA-HF was only nominally significant. Second, the confidence intervals of the two trials with respect to CV death overlap almost entirely. Third point, in trials of type 2 diabetes, EMPA reduced CV death by about 40%, but DAPA reduced CV death by only 2 to 8%. At that time, no one thought that EMPA exerted a mortality effect that DAPA did not have. And in heart failure, DAPA reduced CV death by 18%, and EMPA reduced CV death by 8%. Packer said that no one should make comparisons of estimates across trials because different populations were studied under different conditions, and there's a play of chance. Now, also on the Heart.org Medscape Cardiology is a nice video from Professor John McMurray, who is PI of the DAPA heart failure trial. I'll link to that, and I would recommend that video as well. Now to the DAPA CKD trial. This was the other large SGLT2 inhibitor trial, and it was primarily a renal outcomes trial, but there were interesting cardiovascular outcomes presented as secondary endpoints. This was about 4,300 patients with CKD. Their GFRs were reduced from 25% to 75%, and they had albuminuria. It was dapagliflozin versus placebo. The primary endpoint was a composite of a 50% decline in GFR, or end-stage kidney disease, or a renal death, or a CV death. There were 197 events in the DAPA arm, 312 in the placebo arm. That hazard ratio was 0.61, and again, a highly significant p-value, so a 39% relative risk reduction, absolute risk reduction about 5%. Now, this reduction was seen in diabetics and non-diabetics. The secondary endpoints of CV death or heart failure hospitalization were also lower in the DAPA arm, and all-cause mortality too was lower by 31% in relative terms with DAPA. Now, the trial's not yet published. In both trials, adverse events were low and not much different. And you all know that I like to be cautious. And it is true that most of the benefit of these drugs seems to be in reduction of heart failure hospitalizations. But the effects of SGLT2 inhibitors are consistent across trials. There's CV death reduction, overall death signals are favorable, renal preservation looks consistent, side effects are not awful, and the benefit is seen in non-diabetics and diabetics alike. I just can't see how this isn't a new class of drugs in cardiology, not just endocrinology. Okay, next trial at ESC, we'll move into the AFib trials, is RATE-AF. Now, the surprise, I think, of ESC came with the favorable results from a digoxin trial. DIG, can you believe it? Professor Deepak Kotecha from the University of Birmingham presented results of the RATE-AF trial that compared digoxin versus bisoprolol in patients with permanent AFib. Now, the first thing to say about this trial is kudos to the research team for studying permanent AFib. Most of the research in AFib goes to PAF and persistent AFib because, of course, those can be ablated. Thing is, though, probably half of the millions of patients with AFib have permanent AFib. So this was a study of about 160 patients who were randomized to either digoxin or bisoprolol. Their primary endpoint was laudable because they looked at patient-reported quality of life measures, which obviously that's an important measure. The secondary endpoints included more typical things like NT-BNP, EF, and clinical events. Sit down for the results. Heart rate responses were identical. Physical function at 6 months, which was the primary efficacy endpoint, was not significantly different in either group. But more than half the patients receiving DIG, compared with less than 10% on beta blockers, improved more than 2 classes in the modified ERA symptom score. Now, modified ERA symptom score for AFib is similar to NYHA for heart failure. It ranges from 1 to 4. Over 6 to 12 months, improvement in NYHA functional class and NT-proBNP was significantly greater in the digoxin arm. EF remained unchanged in both arms. Now, this trial was not powered for clinical events, but there were fewer all-cause deaths, 4 versus 7, fewer CV deaths, 3 versus 15, and fewer adverse events, 29 versus 142 in the digoxin arm. Well, in their excitement, the authors overreached a bit on their conclusions, and they said that DIG could be considered first line for rate control in permanent AFib. I love this trial, but there are reasons for caution. And first of all, this was an oral presentation. The details of the paper will be key. We need to see that manuscript. I'd like to know how they used DIG, did they do drug levels, etc. Also, remember, DIG use has a narrow therapeutic window. Clinicians who use DIG have to consider drug-drug interactions and renal clearance, and these things are much easier to do in a trial than they are in a busy practice, so that gets to the external validity. Another reason for caution was the open-label nature of the trial. Beta blockers have strong nocebo effects, and this may bias the self-assessment of physical functioning. And that means that when you put a patient on a beta blocker, they already have a preconceived notion that they're going to feel worse. But despite these limitations, the fact that DIG performed as well as or better than beta blockers in patient-reported outcomes and objective measures like BNP is quite surprising. The numerically lower clinical events were also reassuring, though the trial was not powered for these events. The translation of not powered means that this could just be statistical noise because of the small numbers of patients in the trial. The authors wrote in their protocol paper that this trial will also act as a feasibility study to plan a future event-driven clinical trial that will explore the impact of different rate control strategies on events and unplanned hospital admissions. Besides these stunning results, another reason this trial excites me is the DIG backstory, namely that DIG has been unfairly made into a toxic drug. I say unfairly because the studies that caused its fall from favor were non-randomized observational studies. The problem with those sorts of studies is that no matter the statistical adjustments, is that the reason DIG looked bad is likely to be due to selection bias. That is, clinicians chose to use digoxin in sicker patients, and that drove the association with higher mortality. RATE-AF shows again the power of randomization. In addition to the specifics of AF care, it humbles us regarding the temptation to make causal claims from non-randomized observational data. The next topic is the EAST-AFNet trial. Now that's a long name, so from now on I'll just refer to it simply as the EAST trial. And it asked a highly relevant question. Would an early rhythm control approach to patients with AF improve clinical outcomes versus a conventional strategy of mostly rate control? The background here is that early rhythm control might prevent unfavorable atrial and ventricular remodeling, and that could cause better CV outcomes. But on the other hand, rhythm control is complicated. AFib ablation is inelegant, and it comes with a finite risk for complications. Antiarrhythmic drugs are even more inelegant and surely come with adverse effects. This is why you need an RCT. At ESC, in a hotline, Professor Paulos Kirchhoff presented the trial, and New England Journal of Medicine published it. It was a highly pragmatic study, and it overflows with important lessons. Well, this was a multi-center trial in Europe that included a wide variety of non-permanent forms of AFib. Patients in the trial could have new AFib, paroxysmal AFib, persistent AFib, and even asymptomatic AFib. The trial randomized about 2,800 patients to either early rhythm control or usual care. Importantly, the trial was open label, though outcomes were adjudicated in a blinded fashion. The authors chose co-primary efficacy endpoints. The first was a composite of cardiovascular death, stroke, hospital admission for heart failure, or hospital admission for ACS, acute coronary syndrome. And the other primary efficacy endpoint was days spent in the hospital. They had a primary safety outcome too, was a composite of death, stroke, or serious adverse events. And the overlap of having stroke and death in both efficacy and safety outcomes is a serious problem. Stay tuned, I'll talk more about that. First, the results. About 90% of both groups continued to receive oral anticoagulant therapy throughout the trial. This is really actually an important point and one of the reasons why the results of EAST differs from the older AFFIRM trial. And early rhythm control was indeed started early. Patients were randomized about a month after their diagnosis. EAST was stopped for efficacy after a median of 5 years. A primary outcome event occurred in 249 patients in the rhythm control arm, 316 in the usual care arm. The hazard ratio was 0.79. Confidence intervals went from 0.66 to 0.94, and the p-value was 0.005. So that's about a 21% relative risk reduction. The absolute risk reduction is smaller, 1.1% per 100 person years, and about 3% over the total of 5 years. Each component of the primary outcome was numerically lower in the rhythm control arm. Now, in a trial of almost 2,800 patients, there were 27 fewer CV deaths in the rhythm control arm. That's 1.0% versus 1.3% per 100 patient years. The average days spent in hospital were similar in both groups. Now, the overall primary safety outcome did not differ significantly between the two treatment arms, but here is the problem. The components of the composite safety outcome diverged. Serious adverse events related to rhythm control therapy occurred in 4.9% of the patients assigned to the early rhythm control and 1.4% of the patients assigned to usual care, so a delta of 3.5%. So then you're asking, well, wait, how could the overall outcomes not be any different? Well, stroke was lower in the rhythm control arm, but the authors had already used this as an efficacy endpoint. Then they used it in the safety composite. That helps dilute the higher rate of serious events in the rhythm control group. And it was the same story with death, though this is more complicated because CV death, cardiovascular death, was lower in the rhythm control group in the efficacy outcomes, and this helped drive the primary efficacy endpoint. And then they used overall death in the safety outcome, but overall death has cardiovascular death as a component. So if you just do some simple subtraction, I subtracted the number of CV deaths in each group from the overall death. You find that non-CV death was 71 and 70 respectively, so about the same. Thus, by using overall death in the safety outcome, the authors further dilute the serious adverse events in the rhythm control arm. Now, this stuff may sound nitpicky, but if not for the overlap in the safety and efficacy outcomes, here's what you would have. You would have a trial that had an absolute risk reduction at 5 years of 3%, which was driven mostly by non-fatal outcomes. That sounds good, but it is counterbalanced by a 3.5% higher rate of serious adverse events with rhythm control. Now, I wrote a column on this trial, and I had other concerns. There were substantial numbers of missing data. Heart failure and ACS admissions are a potentially biased endpoint, and this is an open-label trial. Now, external validity or generalizability concerns are relevant because these were expert centers. In less expert centers, you wonder, would serious adverse events from antiarrhythmic drugs or ablation be a little higher? I hope you take a look at the column and write some comments on it. I will close my discussion on EAST with this. AF ablation was used as a rhythm control strategy, but only 8% of patients in the rhythm control arm got ablated initially and only 20% at 2 years. That is both surprising and it's crucial for translation at the bedside. In summary, early rhythm control may improve outcomes compared with the strategy of rate control, but these potential gains come with a risk for serious adverse events. The EAST trial should not be oversimplified to mean use more antiarrhythmic drugs or do more ablation. Instead, the nuance and trade-offs in these findings strongly support discussing the results with your patients and sharing an understanding. And next week, I'll comment more on other big studies from ESC, and there were other very interesting studies. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a review, tell your friends, and this way other people can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.